Good afternoon and welcome to today's webinar, Quality Improvement and Falls Prevention. I'm Andrew Andresco, Project Coordinator for Transforming Chaplaincy, and we are delighted you could join us. Some housekeeping instructions off the top. The webinar is being recorded. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio or visual, please type those into the chat box located in the platform's dashboard. You will have the opportunity to submit text questions for our presenter by typing your questions into the questions box of the control panel, also located in the platform's dashboard. You may send in your questions at any time during the presentation. We will collect these and hope to include them during a Q&A session at the end of today's event. With that, I'd like to introduce Chaba Salaji, Director of Transforming Chaplaincy. Chaba?
Thank you, Andy. Welcome, everyone. I'm glad you're joining us today. It's my pleasure to introduce today's presenter, Mark Bradley. Mark is the Manager of Spiritual Care and Education at Northwestern Memorial Hospital in Chicago, Illinois. Mark, for over a decade, worked with the Night Ministry Outreach and Health Ministry providing care for the unhoused individuals in Chicago. And in 2014, Mark came to Northwestern Memorial Hospital. He's an ordained minister in the Metro of Chicago region of American Baptist churches. He's an ACPE Certified Educator and a board certified chaplain with the Association of Professional Chaplains. And in my eyes, most importantly, he's also graduate of our Spiritual Care Leadership and Management Certificate program we have at Transforming Chaplaincy. And thank you, Mark, so much for sharing this project and creating this opportunity for us to learn about quality improvement and how we can lead that as chaplains. If other chaplains have led interesting QI projects, please let us know. We would love to hear about it and learn from you as well. As you see on the screen, I also wanted to highlight supporting Transforming Chaplaincy. If you find our webinars and resources valuable, consider supporting us, our organization. And we are at 70% of our fundraising goal for 2023. So next slide, Andy, please. Thank you. So we have two book discounts we wanted to share with you. First is a 40% discount for the book Transforming Chaplaincy, the George Fitchett reader, which provides an excellent overview of George's excellent research over the decades, and including with some reflections and introductions. So it's a really great way to introduce yourselves and your colleagues, your students, to spiritual care research. Next slide, please. The second book, we have the publisher provided us a 20% discount for evidence-based healthcare chaplaincy, a research reader. So this includes selected articles, research articles on wide-ranging topics, and this is a perfect primary text for healthcare chaplaincy research. And so with all this, I'm gonna turn it over to Mark. Thank you.
Thank you very much. Thank you. Thanks for this opportunity. I want to say that I'm both excited about doing this and also terrified at the same time. I want to say one thing about me is you may find in the slides, I think I'm pretty hilarious. My children and other people say that's not true. And even though it's a serious topic, I'm going to try to throw in some slides that are humorous, some cartoons, some other things from pop culture, just to lighten it up a little bit. The other thing I want to say is that the improvement project that I did, I want to make sure it's clear that it was a team effort from the very start. And it's not my intent to say how awesome I am, but if it comes out that the team here of chaplains at Northwestern is awesome, that's successful. So let me share my screen. Okay. Andy, is it good?
No, I can't see it. All I can see is you.
Okay, hold on. We did practice this, right?
We were all set up.
How about now?
There we go.
Okay. Wonderful. So humbling. Such a humbling experience. Okay. So first of all, I want to say this is about quality improvement and a quality improvement project that my team worked on back in 2021. We think it's a pretty awesome project, but you know, you may have more experience than I do in quality improvement. I'm sure a lot of you probably do. Some of it might be new to you, and some of you might kind of in the middle in terms of what you know and your interest. Whenever I watch these webinars, which I watch all the time, I try to find one thing that I can learn. So my hope and prayer for all of you is that maybe you can find one thing. There's probably some things I'll talk about that you already know about. Just, you know, that's fine, but let's try to get one thing out of it. That would be successful to me. Okay. So way back in 2021, my organization, we still have it. We have a quality improvement program called the Improvement Leader Training, or ILT. So this is for managers in the system, also like clinical care coordinators, educational coordinators. It's a leadership program, but it's also meant for leaders to learn how to do quality improvement. At Northwestern, there are a bunch of different ways to do that. Some of them are groups, some of them are individuals. We have a program called LEAD now, where staff can do that as well. We have many of the chaplain staff who are involved in that right now. But this improvement leader training was a lot of work, I just want to say. And this was part of an email that I got back then that said, congratulations on my nomination. It's a very competitive process. Only a few people from each hospital get in. And as you can see on the slide, 20% of my time was supposed to be dedicated to it. I just want to say there was probably more than that. I don't think I realized how much work this would be. But yeah, so it was a lot, can I say. And it lists some of the things that we did. We had online and on-demand work, training, virtual trainings, in-person training. I had a coach, which I think is pretty cool. It's nice to be so well-researched to have a process improvement, project process improvement coach. I had to present at things called improvement councils, where a bunch of the leaders get together and you present in front of them. I did that 3 times, in the beginning, in the middle, and the end. That was a little stressful. And then there's some other things I had to do to graduate, an assessment, evaluation, and then finally a poster, which I'd never done before, on the Northwestern Medicine Improvement Day. And you can see the schedule, started in September, went to June. So it was a lot. And it was successful. So I did get in. And here's the slide that shows that I completed it, just in case it wasn't clear, that I actually completed it in 2021. And the thing that I'm more proud of is my team won the award for Improvement Day. How I mentioned how I did a poster. We did a poster, and on Improvement Day we were the winner. So that's pretty awesome. So that's legit. So like I said, a lot of you might have more experience than I am in all this and know a lot about this, but I got the trophies to prove that we worked hard and put a lot into it. I don't know what process improvement framework that your hospital uses. If you don't know that, I encourage you to find out. We use the DMin program. And so as the previous slide talked about, there's a lot of training in this method. So it just begins with defining the problem and frankly, why I care about that problem. Then you measure the problem, and then you analyze for the root causes, and then you do something like an intervention to improve improve the improvement. And then once that's all done, you do a process to we call control, which just means to sustain it in the long term. So this is the MAIC process. And one of the things that's important in this process, you may have done this before, is a project charter. I'd never done this before. It's a lot of work. and you can see the title up the top, but the problem statement for this was in FY20, Northwestern Memorial Hospital did not meet its goal of an average of 37 falls per month. A general medicine unit and an oncology unit had an average of 3 patients per month experience a fall. These two clinical units account for 16.6 of the total number of falls. According to the recent monthly data, these units are on the same trajectory for FY21. The goal remains 37 falls or less per month. And so you can see that it was a significant issue. And so I had to show what the problem was, and then also add some numbers in there to talk about, well, why does it even matter? Why are we even doing this? It talks about the goals. We wanted to reduce the average number of monthly falls for each pilot unit by 10%. The area of focus would be these 2 units, not the whole hospital, just these 2 specific units. And then out of scope were all the other units, all the other hospitals, etc. And also, it's also on weekdays as well, that we only did it on weekdays. Then you can see some of the definitions of success, some of the things we were trying to provide, the outcome metric, process metric. Then on the other side has the milestones. It just shows how we went through the different stages. Down the bottom shows the team. Our amazing vice president, Kristen Ramsey, was the guest sponsor. Sarah Casino, who was my director at the time, was the sponsor. I was the process owner. And then these team members, like I mentioned earlier, we have a falls committee, Megan Malati, Sheila Wade, Kendra Howard, Christine Senkowitz, Michael Washington, and Andrea Horton were like the core team putting this all together. There were many other people who worked, both chaplain residents and chaplains who worked doing the interventions in the project, so they should get all the credit. Okay. So in this thematic model, the first thing is to identify a problem. And if you don't know already, falls is a major issue. Preventing patient falls, especially falls with injury, is a major issue in healthcare. It's everywhere. Some other major issues that I hear about are like pressure injuries, reducing those, also like infections from catheters. But more and more, I just hear about how patient falls, how we want to reduce patient falls. We'll do pretty much anything to reduce patient falls. So in things like this leapfrog, or the safety grade, the Joint Commission, it's important to them. Magnet status is a very important part of that. I found this one slide down the bottom. It talks about falls prevention being a safety priority, how reducing injuries from falls can increase quality of life for clients and reduce costs. Of course, quality of life for clients is awesome, but if you can also show that you can reduce costs, it's equally pretty awesome. And then I took a clip down the bottom. It says Culture of Safety Survey launches April 11th. So every year we get a Culture of Safety survey. And I remember at least 3 or 4 years back, as chaplains, we'd fill this out and we'd be like, well, I don't think this applies to us. What kind of safety? How do we contribute to safety? How do we? And so this was also an attempt to say, yes, we can also contribute to the safety. This is the grade for Northwestern Memorial Hospital on Leapfrog. This is just public knowledge. If you go onto this website, you can put in your own hospital and see what your grade is, and see how you can look at the score, and then it narrows it down to safety problems, and falls is a major part of that. So patient falls and injuries, falls causing broken hips, those kinds of things. So that's just showing that on the Leapfrog how important falls is to the safety, the grade that we get from safety. So I think I see a big part of my job is aligning to what's important to the hospital. And so looking at what are the goals and priorities of the hospital that we work for, and then aligning our work to that, being part of that. And that's all fine, and that's definitely a big part of this project. But I want to say, more than that, I think the impetus for doing this project was really in these post-fall huddles. And so whenever there's a serious fall with injury at the hospital, the managers have a huddle where they talk about these things. It's not about blaming people, but what went right, what went wrong, what went almost wrong, how can we do it better? And it's really going over the case and trying to think about what we could have done differently to prevent the fall, and how we can do this better. And it was in those times when I saw the angst of the nurse managers and heard stories about the PCT or the nurse who found the person on the ground and how horrible they felt. And of course, hearing stories about people having serious injuries and going to the intensive cares. It really touched me on a deep level, I think on a heart level, I guess on an empathetic, a compassionate level. So even though it was clear to me that I wanted to do this for reasons, strategy reasons, kind of aligning, showing value to the institution for the chaplains, in the end, I think what pushed me was just a typical chaplain thing of wanting to help people, being compassionate and caring and coming from the heart. So there is an issue. People fall, and it's very important to the hospital to prevent falls. And at these safety huddles, we're trying to figure out what can we do. How can we help prevent falls? No one was really considering back in 2021 that the chaplains could do anything to prevent patient falls. The chaplains weren't thinking about it. I had this idea in the back of my head, and I was sitting in these post-huddle meetings thinking, I've got to do something. We need to help. We should be part of this. We should be preventing falls as well. So this is one of our pictures back in 2021. This is not all of our people. But you can see some of the interns, some staff chaplains, some of the residents in there. These are people who were part of the team putting this project together. So when the call went out, who can help prevent falls? The typical people, the nurse managers and the nurses, the PCTs were saying, yeah, we'll do this. And I stepped up and said, yes, the chaplains will do it as well. And this slide really, another Ghostbuster slide, is really about, we're ready to believe you in the sense that this is the chaplain team ready to believe that this is an important issue. I'm sure there are people on this call who think that safety and falls prevention isn't what chaplains do, and chaplains should never do that. So in this case, you can see the pivot I'm making to say, yes, we believe falls is important to the hospital, and we're going to be, we say, true believers. We're going to believe and we're going to do something to try to help. Just like in the Ghostbusters movie where people were experiencing ghosts, and a lot of people were saying, no, no, no. And the Ghostbusters stepped in and said, yes, we can do that. We can help out. In this one, I think I'm Darth Vader, I want to say. And some of you might be thinking that now as we think about some of this kind of a pivot in terms of spiritual care, not typical spiritual care kind of stuff to be involved in falls prevention. I want to say that at the time, I felt a little disturbance in the force because I was really trying to convince people that we should try this. Now, people were open to it. All the leadership were open to it. Everybody was open to it in the sense we want to do anything we can to prevent falls, even include the chaplains. But there were some people who were thinking, no, that's not the chaplain role. Chaplains shouldn't do that. Both chaplains, leaders, I thought about it myself, still do sometimes. And so there were people who said, well, chaplains, this is what chaplains should be doing. And a lot of it is about religious care, and now, spiritual care. Someone said to me, what are chaplains going to do about falls prevention? Are they going to pray it away? That disturbed me. So this down in the right-hand corner says, I find your lack of originality disturbing. That was part of it too. One of the big things about belonging to this hospital is that we want to do new things, innovative things, breakthrough kind of things. And I felt this was something that was innovative, that hadn't been done before, and that it was important. And so, we kept going with this, even when some people were doubting. I learned very quickly the way to get support in a project like this is to show that it's evidence-based. Now, there are a lot of do-gooder types. I think most of us probably on this call are really do-gooders. We want to do the right thing. We have good intentions. That's all fine, but at least where I work, it's all about evidence-based care. And so showing that you can use evidence-based care in projects. And so that's really how I sold it. And I wonder, that one slide on, that one little picture down the bottom about evidence-based practice, do you love it or loathe it? I wonder, I don't have a poll here, but consider, do you love it? Do you loathe it? Think for your own self, or are you somewhere in the middle? I've always been someone who was more on the love side, but I know there are people who still kind of loathe it. I remember years back, I want to say, I don't know, 10 years ago, being at something, I think it was at APC conference, and George and a few other people were doing presentation. It felt like at least half the room were like, no, we're not going to do this. We've come a long way since then in terms of research and evidence-based practice, and I think we're learning to love it, but there still may be some who loathe it. So the evidence-based practice that we use, that we sold, that we promoted is motivational interviewing. And some of you might know a lot about that, and some very little. In our world here, in the healthcare world, it's kind of a word people know. They might not know exactly how to do it or be trained in it, but they know something about it, and it's very easy to show that it's evidence-based. This is something that chaplains here have been doing for a long time, about 10 years. It was something we did at the night ministry as well. So we've been training chaplains in motivation interviewing already for almost 10 years. And so when the opportunity came to use this practice, use our skills in motivation interviewing, this was a perfect thing to do. Now, if you don't know a whole lot, I'm going to have a few slides about motivation interviewing. Of course, the first part is here, it's evidence-based, which was the selling point at the hospital. The cool thing about motivation interviewing is it's directive, but it also employs skillful listening. There's a collaborative relationship using directive listening techniques and trying to address clients' ambivalence, their reluctance to make changes, and trying to connect it to their own personal motivations. Motivation interviewing, or MI, began in the 80s. Up to the right are the founders. In the middle is, I think, the most recent book, the third edition. That's the Bible of motivation interviewing. They started doing with people who were struggling with addiction because it wasn't working. The process back then wasn't working for everybody, so they were trying to find new approaches. Nowadays, there are so many of these books out there. It's very clearly considered to be evidence-based. So there's one about treating psychological problems. There's one about healthcare, higher education, offenders, nutrition and fitness. And the one I always think is cool is about dentistry. I would put money down that your dentist knows something about motivation or interviewing. I know my dentist, over the time, the one I have now, I bet you he studied some of this. First of all, you'll probably notice they're less judgmental and confrontational these days. I think years ago they might say, if you don't brush your teeth are all going to fall out. And why didn't you come visit me earlier? You haven't been here for 6 months. Why didn't you come? They're much more collaborative these days. They're better listeners. And all of that, I think, is using some of these approaches in motivation interviewing. The other beautiful thing about motivation interviewing is anybody can use it. It's not considered only for psychologists or therapists, or that is something that anybody can use. And so at our place, occupational therapists, physical therapists, clinical nutrition, dietitians all use this as well. And so chaplains and social workers use it. We all use it. So it's like a common language. This is the motivation interviewing spirit. I think in trainings when I've been studying about motivation interviewing in the many trainings that I've done over the years, spirit is said to be the most important piece. And some of the aspects of that are collaboration, where you really collaborate with the patient. You're working together in a partnership. It's not one person having all the knowledge and the other person have none. You both are experts, and you're using, it's like a mutual relationship, mutual expertise kind of relationship. That's really important. The autonomy, knowing that people make their own decisions, that and we support them doing that. Compassion, that underlying all this is having a compassionate, non-judgmental approach. Unconditional positive regard. It's a very humanistic-based Rogerian approach on that level. And then evocation is really drawing out things from the patient. So example of this, years ago I would talk about, I'm going in to see the patient and I'm bringing God, or I'm going in to see the patient and I'm bringing them hope. I think a more motivation interviewing approach using MI Spirit would be, I'm going to find the hope I'm going to draw out the hope within the patient, or God's already in the room or in the patient, I'm drawing that out, or I'm bringing out their goodness. That's a different kind of approach than I was brought up with early on in ministry. This is a funny little slide. If you've ever wondered about motivation interviewing, and if it's successful or not, you want it to be like the Patrick Swayze about the dancing thing there. You want it to be like dancing, not wrestling or wrestling. When I was growing up, all of us have had patient encounters where it seemed like we were wrestling. Other ones might be dancing. So it's a dance as in it's a give and take, and then how you're working together, how you're moving together. You have different roles and you're following each other, working together versus struggling and working against each other in wrestling. And then this is the test for you about motivation interviewing. Whenever I show this slide, I think a lot of us really think that's pretty awesome. I wish we could do that, but it's not motivation interviewing. If you're wondering, it's not seen as an effective way to help somebody make changes in their life. Being confrontational really doesn't seem to work. There's always exceptions to everything, but in general, the evidence shows being confrontational with somebody, being judgmental, really doesn't bring about behavioral change. What it does is it pushes the behavior underneath. We saw this, in Peanuts with Lucy and Charlie Brown. She's, pointing her finger, and that little girl there as well. I love that picture as well. Being confrontational, whether it's in any time, really doesn't seem to work. You want to have a collaborative relationship, a partnership with the patient in order to make some changes in their lives. And then the bottom, this cartoon as well, just talks about how this person really stopped listening to their doctor, because all he ever said or she ever said was stop overeating, stop drinking, stop staying out late, all these kinds of things, and he just stopped listening. It was not a motivation interviewing approach. And they call this the writing reflex. And the writing reflex really, underneath that is like, we know what people need to do, and we have all the answers for people. All they need to do is like listen to us and follow what we're doing. And if we confront them enough and make things uncomfortable and shame them or embarrass them enough, then they'll make a change. Another thing in motivation interviewing that you would learn, many of you probably learned already, but if you go to some trainings, these are the 4 basic skills: expressing empathy. So in motivation interviewing, empathy is about giving people the benefit of the doubt. And it's really looking, it's a very positive approach, a very optimistic approach to people. The example they always use, because some of us have trouble doing this, is if somebody cuts you off in traffic, can you give them the benefit of the doubt? I know that's really hard for me. Even commuting this morning, if someone cuts me off, I'm like, I'm thinking very judgmental. I want to confront them, say things to them. And motivation interviewing, those are times when you can practice it and give that driver the benefit of the doubt. good luck with that one. But that's a key skill in motivation interviewing. The developing the discrepancy is just helping people see where they are now and where they want to be, and then show the discrepancy and talk about how they might get there with them, partner with them. Rolling with resistance is sometimes we think that if people aren't making changes, or then they're being resistant and it's all their problem, the patient's problem. They need to, correct themselves. They need to be more moral. They need to be smarter, whatever you want to put in there. But in motivation interviewing, it's very clear the approach is, it's us. If the patient seems to be resistant, then we need to change our approach, which is a totally different way of looking at it. And then finally, just promoting self-efficacy, knowing how important it is for people to make their own decisions. We might not like the decisions that people are making, spending a lot of time with them. Still, they're not making decisions we think are the best decisions, but being able to support them in that. And then this is another really important motivation interviewing, is figuring out what stage people are in. So pre-contemplation is when people don't realize or have any awareness that they have a problem with something. Contemplation is starting to think about it. Preparation, and then action is like realizing that they want to change, that they're going to change, and then actually going through the change. Maintenance is like sustaining it, keeping it up. And then you get to the part where you either kind of fix that problem or you solve that, or then it goes back and you relapse, which for many of us, I think when we try to make a change in our life, it ends up being more in the relapse, and then we start the cycle again. This is just an example of the change cycle. So over here is someone's either unwilling to change or just happy with the way things are. They don't think they have a problem. Then they're thinking about the change, deciding the change. This is the action state, taking action. They've made a change and they're committed to the change. Sometimes that remains permanent, but other times it just keeps going around. And you can fit anything in there, any kind of thing. But of course, coming back to the falls thing, I found this somewhere where it said 92% of patient falls start with, "It won't happen to me," which says to me that a lot of people in the hospital feel like they're not going to fall, or that's not an issue for them. They don't need to worry about that. That's not a problem. Patient falls has nothing to do with them. So it ends up really, for a lot of the folks that we meet, they're going to be in the pre-contemplation stage where they don't realize there's any problem. They're happy with the way things are. We have talked to staff. We look at the chart. We know that I think the risk seems pretty high, but they're not aware of it. Okay, so back to the ILT project. Like I said, it was in 2021. We did it on these 2 units. One was in general medicine, one was in oncology. It was 3 months long. It was the weekdays. All these patients needed to be alert and oriented, and English speakers in this case. Chaplains did interventions using motivation interviewing. Very important part of this is working with the clinical coordinator and the nurses on the units to identify people with the highest risk for falling, with injury. We use a safety activity plan that's in the chart. We explore barriers and root causes, and we help patients resolve their ambivalence. So these are some of the feedback we got from patients. We realized very early on what we were going to help people with, what patients needed the most help about to resolve around patient falls was, it's really hard for people to ask for help. It's hard for me. It's probably hard for you sometimes or all the time. It's very hard for patients to ask for help, and that's something we work through with patients, with their ambivalence about that. And other times you hear people saying, well, I feel like a burden. I don't want to ask the nurse. They're busy. It doesn't matter. You know what I mean? There are other things more important than that, so I'm going to get up. A lot of these falls, if you didn't know it already, have to do with like getting to the bathroom. This is a process map that I developed it when I first did this with my director and coach who were working on this. I had like 3 different things in my process, and they helped me do this. This is something you would probably do with a project like this. And so you can see there's a report that the chaplain runs. Chaplains create a list based on whether the person's fallen before and their risks according to the chart, we use EPIC. Chaplain checks in with the clinical coordinator and asks those questions. Patient prints out the safe activity plan, which I'll show you in a little bit, and brings to the patient, asks the patient if they'd like to participate. Sometimes they say no, you go to the next patient. If they say yes, then you have a session with them using motivational interviewing and discussing their safe activity plan. These are the things you discuss with the RN afterwards. You document it, and we use a SMART phrase. And then one of the things I think is interesting, once you do that initial assessment, how do you know how many times to follow up? Is it going to be like one visit, 2 visits, 3 visits? I think that's an interesting piece. Most of the other disciplines I think that we work with have something like that. They see someone's having an issue they're struggling with, and they're like, this person needs 3 interventions or 3 sessions with me. That's kind of the thing we are working towards. Then the other thing, there's a question mark on the fall. This is something we're still continuing to work on units. Sometimes it happens, sometimes it doesn't. We're hoping that when there is a fall in a unit that they actually call the chaplain and let them know or send us an order so that we can re-engage with those patients and then start over. This is a safe activity plan. You can see, so this is something that's in the chart. This is something that I think is encouraged to be in the patient's room so they can look at it. But you can see what it says, my care team commits to doing this, and I will commit to doing this. So the chaplains print this out and bring it. And this is part of the discussion they have with the patient. This is the script that they used back then. We've adapted it some, but basically it's introducing ourselves and asking them would they like to discuss their safety. These are some of the interventions these are from chart notes. You can see some of the work that the chaplains were doing in their interventions. Talks about the patient was aware of their fall risk, and they wanted emotional, spiritual support, loss and grief, instead of a falls risk assessment. So oftentimes chaplains would go, they would see somebody who's a patient who's a high-risk patient. This patient may not be on the chaplain consult list or on the regular list for the chaplain to visit. Maybe they didn't ask for a chaplain to visit. But chaplains would go because they were high risk for falling. Once they get there, they'd find, oh yeah, this person doesn't seem to want to talk about their fall risk as much. What they need right now is more traditional spiritual care, like emotional, spiritual support. The beauty is, of course, that many times you can go back and maybe there's another visit, a traditional spiritual care visit, or get to talk about falls prevention once you build that rapport. Second intervention, the patient didn't believe that they didn't believe or know that they were at fall risk. The medical team had big concerns about that. They talked about how they were frustrated, that when they asked for them to go to the bathroom, it seems to take the nurse so long. Patient talked about the last night. They were frustrated because they were waiting and they went by themselves. Luckily, they didn't fall that time, but they could fall next time. So the the chaplain worked with the patient and also ended up working with the nurse to figure out a plan to deal with that. And then another one was talks about the patient is having difficulty talking, although alert and communicative. Patient remembers the last conversation. Patient still upset about toiling plan, but said that she would not try to go to the bathroom by herself. I think that should be, but she said she would try to go to the bathroom by herself. So the idea behind this is that you had this conversation. The patient said she's still upset, but she agreed to call before she goes to the bathroom. And then I think this ends up being the most successful work that we do when we have a patient who's at high fall risk, especially for injury, and we have multiple visits. And so somebody that we see multiple times. Some of these fall interventions, we just saw the person once or maybe twice, but it feels like when I look at all the data, it seems like the most successful has been the multiple visits. So this just shows somebody who was seen 4 times At the first visit, in the chart notes, talked about the patient didn't have a clear understanding of their need for assistance. By the second visit, they were able to articulate steps, and they wanted to talk about the safe activity plan. And then really, in the third visit, they really got to the crux of the issue. And this is why chaplains are so good at doing this, because the chaplain built that rapport with the patient and are such good listeners that they were able to see that the patient doesn't want to ask for help because it hurts when other people touch her. People don't always say that to other healthcare team members, but they'll talk about that with the chaplain. And so then the chaplain discussed with her and the nurses about modifying their assistance so that they could minimize or eliminate her pain. And then by the fourth visit, the patient has made a turn. They're fully aware. She's fully aware of her risk for falling. When asked whether she better understood her unwillingness to allow nurses to contribute to her falling, she stated she did, but the pain of having someone touch her outweighs the risk of falling. So she expressed desire to modify her behavior. The chaplain gave another copy of the safe activity plan, working with the nurses and the chaplain. That's the collaboration, the partnership. And so the safe activity plan was also put in the room. That patient didn't fall at the hospital while they were here. So at the end of the pilot, these were the results. On those units, there were 66 beds. The chaplains did 53 interventions, and none of those patients fell post-chaplain intervention. Can you see how this is important? Going back to the original slide. So of all the people that the chaplain saw, the patients that were high risk of falling, they did the interventions with them, and none of them fell after the chaplain did the intervention. So if you look at the graph down below, you can see the percentage of people who fell in those pilot units, those 2 units, 5% during that 3-month period. And in our intervention group, 0% fell. I want to say that we did this again a couple months later. We wanted to do the intervention, the same kind of thing, but we wanted to have at least 100 interventions. We did it again. We had over 100 interventions this time. Also, 0% falls post-intervention. So, seems like it worked. Seems like it's successful. You can see how people were excited about this. This just shows another graph. So what I want to say, if you see the yellow here, that's the oncology unit. And everybody knows in oncology, you tend to have more long-term relationships with people and multiple visits. Although in general medicine that happens sometimes, but in general. And I feel like the fall rate is lower there, and this is during the time when we did the intervention because of the multiple visits we had, the multiple interventions we did with patients during that time. I'm not sure I said that 100% clearly, but I think this just shows how effective we are when we do multiple interventions with these patients. So this is updated. So we're still doing this, I should say. We're still doing this. We did the pilot, we did another pilot. We're still doing it now. So we started, April 1st, 2021. This goes up till yesterday. The data, I pulled the data. You can see that there are more units we're doing it on. Now we're doing it on many more units with 285 beds, both general medicine and all of oncology. We have done so far 467 interventions. So our fall is post-intervention, not 0%. We didn't think it would be 0% forever, but still at 2.3, which is definitely at least about half of what patients without the chaplain interventions are on those units. I want to say, put this extra slide in because our chaplains are using this now. The beautiful thing about this is over time, that the chaplains have really helped develop this, helped it to evolve. and adding the BMAT to our process has been really helpful. So, couple of slides left. For this slide, whose fault is it when a patient falls in the hospital? Of course, nobody's fault in these process improvement projects. We don't want to, put blame on anybody. But in this project, very clearly, we were trying to say that chaplains can make a difference in terms of falls. We want to be part of the team. We want to help prevent falls like everyone else. We want to add value to the institution. We don't want people falling. We don't want people getting hurt. We don't want nurses experiencing their patients falling, because that's such a horrible situation. And so working together, I think this project really showed that chaplains really can make a difference in terms of decreasing patient falls. Not that we figured it all out, but we're still developing it, or we're still training our people. I think we're getting better at it. But I think in the end, this was a very worthwhile project. And where do we go from here? I'm saying we keep evolving, and the chaplains, like I said, have taken ownership of this, and they've brought new things in, like the BMAT and other things, focusing on specific populations and oncology. And so, who knows? But it seems like we're moving ahead. The last is about slides about questions, and I believe I'm done. I'm going to try to stop sharing. Did I stop sharing?
Yes. Awesome. Thank you so much for your presentation. I really appreciated the innovative ways of bringing chaplaincy skills to the table and really making a tangible difference, as well as the way that you aligned with healthcare needs and priorities at your institution, like to really address the need that was on everybody's mind and was a pressure point for the whole system and the team. Starting with one question from the audience. I understand that your project dealt with alert and oriented patients. Have you conceptualized a chaplain approach for preventing falls in people living with dementia? So if you look at a different patient population, what are your thoughts about that?
Is that one of my chaplains that put that in? I don't know who put that in, but we were talking about this issue this morning.
Oh, great.
There's a couple issues. A couple of the units that really have a lot of people with dementia, and a lot of those people end up falling. We have not figured out an intervention with them as of yet. And so the process we're doing now really does seem to focus on people with capacity and not people who have dementia, but it still is a big issue in healthcare around falls. The people with dementia, a lot of those people fall. So we're not there yet. We haven't figured that out. So that might actually be a limitation, but like I said, we're always trying to evolve it to see.
I had a question about, like you have done a couple of iterations of this project, and you really, like the difference and the way that chaplains were contributing to the team was really unique. I wonder kind of how you see that maybe stakeholders' perceptions on spiritual care and chaplaincy may have shifted, or how the support reception of spiritual care, seeing chaplains in this new role, maybe there's a increased frequency of interacting with the team and chaplains. So I wonder how kind of that changed maybe units or even for the organization in the ways they see chaplains.
Yeah, I think we're very fortunate here. I've been here almost 10 years, and chaplains are very well respected and are called constantly for things here. So we came in even before this project being very considered essential, even during the pandemic and otherwise. And so I think I've been in different meetings, like manager meetings with all the nurse managers, and different nurse managers bring it up. oh yeah, you should call the chaplain for falls. And so even though I've been promoting it, it's always nice to see one of the nurse managers get up and say, oh yeah, have you thought about calling the chaplain after a patient falls? So the nurse managers, I think, are buying in on it. I also think a lot of the work we're doing now, we have a process of a project now in oncology, and it's working with PTs and the OTs around falls. And so that's like, in our mind, the perfect project because it's interdisciplinary. Mm-hmm. And so I think that the PTs and OTs have really bought into the idea. Yeah, chaplains can be part of this and make a difference. And so I want to think that overall it's improved, our relationships interdisciplinary. So if we look back over the last 10 years, definitely we're doing a lot more visits now. So it can't hurt. Yeah. But I'm not sure it's perfectly aligned.
And I really, love you showed the evaluation and the numbers. What did they say when they saw your numbers in terms of the 0%?
People, at least at my institution, would do anything to decrease falls, and so people were ecstatic. You saw the trophies, right? That award, and it was a big deal, I think, and to show that it was a different way of looking at things that could reduce falls. People are very excited. So made a lot of believers.
And I have two more questions from audience, and I think they kind of get to that theme that I appreciated you highlighted when fall prevention visits led to spiritual care conversations and spiritual care visits, and then spiritual care interventions led to fall prevention conversations and interventions. I like that fluidity and back and forth, and how that kind of goes to and gets to deeper factors impacting behaviors and how people may ask or not ask for help and assistance. So the question is about how did you conceive chaplains to be part of this project? How did you convince chaplains to be part of this project if they felt it was outside of their scope or they felt it was not spiritual care to be doing the fall prevention visits?
Yeah, I don't think anybody ever said it's outside our scope. I think that, like I said at the beginning, sharing stories about falls and the effects that it has on patients and also on staff. My team spends a lot of time on staff support. They're very connected to staff. And I didn't think it took much convincing to show that I thought, that we could reduce suffering on staff suffering in these situations. We could also, reduce patients going to the ICUs and being injured by these. And so, I think with certain leaders, I think I really went for the head approach, I guess if you say, the strategy, the data and stuff. I think with the chaplains, it's always the heart stuff. And so I think that's what pushed me into it. And so I think that's the reason. So
great. And another question asks, in what percentage, and kind of continuing this theme, in what percentage of your interventions did the motivational interviewing lead to a deeper spiritual conversation? So if you have whether you have numbers or kind of your perception of those conversations leading to deeper spiritual conversations.
Yeah, I think I don't want to over exaggerate it, I guess, but I know there are definitely times when the chaplains have told me that that's been the case. I know, one thing I'll share is I do rounding, sometimes with my boss, sometimes by myself, of patients, like patient satisfaction kind of rounding. I get into conversations with them, and sometimes safety comes up and falls comes up as part of our conversation. So even when I'm doing rounding, I end up doing one of these interventions with them in that moment. So there's all kinds of ways to fit these things together. And it's not perfect in any way, but it's, we're growing, it's evolving.
Awesome.
Great question.
And I appreciated kind of you highlighting that, with chaplains you had appeal to the heart and the stories and how preventing, reducing suffering, and with the organization you had a more strategic approach, kind of going with the thinking side of things. And you already kind of alluded to that kind of next steps. You have continued this intervention up to today, and kind of next steps working with PT and OT. So with that, or just kind of my question was kind of what some of the future directions, or if there are similar projects that you are excited about tackling at your institution.
Yeah. So I think, if we're going to kind of enhance it at this hospital, we would just end up doing more units. We're still limited to those general medicine and oncology. Someday maybe we'll do more units. One of the things that excites me is one of our chaplains found an article on heart failure patients and self-care, where heart failure practitioners were assessing patients' self-care, and had a whole standardized kind of survey. And then we're doing interventions using motivational interviewing around self-care. And so I've talked to our cardiology chaplains here about this, trying to bring in using motivational interviewing in terms of heart failure patients, and then working on self-care issues. Because I think all of us know that a lot of our conversations with patients tend to be about self-care. And so we're already doing these self-care conversations, are we doing the motivational interviewing? And so if we can align it to the heart failure patients based on research that's already being done, that's shown to be effective, I see that as an opportunity. I think mindfulness as well is another evidence-based intervention, is another area I think we want to grow in. And, those are, some of the ways I think hopefully things will go in the future.
Awesome. Thank you so much for, and I'll look forward to hearing some of your results from, working with PTOT as well as working with heart failure patients, and just the way that you connect the existing evidence, and that's just a great example of how to create evidence-based interventions and initiatives to look at the evidence, what we can learn from it, and how we can translate into practice, and then then measuring our outcomes and our results and the difference that we are making in that area. Thank you so much again for your presentation. I loved having you with us today, and thank you for everyone for joining us.